Good evening. This is SPTA, Todd Boland, reporting on patient Brenda Harper. Patient Brenda Harper is a 57-year-old woman. Patient Brenda Harper has a long history of bilateral knee pain. Patient Brenda Harper's knee pain is caused by osteoarthritis. Patient described pain with walking, sitting too long, going up and down stairs. She had recurrent swelling of the right knee joint. She tried analgesics and narcotics, as well as non-steroid anti-inflammatory drugs, with only temporary relief. A previous physical therapy regimen was also unsuccessful in relieving her pain. The patient received a steroid injection into the right knee, which did provide some good relief, but for only about 5 weeks. Patient was limited in mobility and stability, which limited participation in previous activities of daily life, like walking, bathing, dressing, cooking, gardening, driving. The condition is debilitating. The patient's participation by limiting the ability to continue playing golf, the patient's favorite activity. What is a total knee replacement, you ask? Well, let me tell you, it's no fun. Total knee replacement is when the surgeon removes bone and diseased cartilage from where the femur and the tibia meet at the knee joint. Those surfaces are then replaced with a metal implant. A piece of special plastic is used to replace the backside of the kneecap, and the same special plastic material is placed in between the two metal parts. This gives both bones in the knee joint smooth surfaces so they can flex and bend more freely and painlessly. The decision to perform surgery was due to severe pain and disability from chronic osteoarthritis, which is the #1 cause of total knee replacements. Now, total knee replacements are usually done one knee at a time so that they have a good leg to use during rehabilitation. But if both knees are already in pretty poor shape, it does make sense in certain scenarios to do both at the same time, like in this situation. Patients are always instructed to do an exercise program before surgery to strengthen the affected muscles. In this case, the quads, hip abductors, the hip adductors, and knee flexors are important to strengthen before surgery if you want a speedier recovery post-surgery. The patient does have some challenging physiological factors affecting rehabilitation. The patient suffers from osteoarthritis in the spine and hips. The patient is obese and has diabetes. Patient has stress, urinary incontinence, and severe anxiety. The patient needs medication before each treatment just to numb the pain. patient's gait is affected by limited range of motion from the surgery and weakness of the lower extremity joints due to obesity. Pain limits the patient's participation, causing the range of motion progress to be slow. The patient demonstrates motivation to participate in rehabilitation and has emotional support from a boyfriend and other friends who visit regularly. The patient has family, but they live in a different state. The patient lives in an apartment that requires 2 sets of stairs. One set has 8 steps, the other 6, both with railings on one side. The boyfriend works full-time and cannot be there during the day, but the boyfriend can be there at night to help if needed. Precautions. Respirator methicillin-resistant Staphylococcus aureus, MRSA, which is a bacterium that causes infections in different parts of the body. It's tougher to treat than most strains of Staphylococcus aureus because it's resistant to some commonly used antibiotics. The patient's diabetic evaluation: intact light touch, temperature and pain sensations in bilateral lower extremities. Patient has hammer toes and extra dry skin. Patient's medication: venlafaxine, 50 milligrams 3 times daily for anxiety and nerve pain. Naproxen, 250 milligrams twice daily to relieve pain and inflammation. Side effects of venlafaxine: nausea, headaches, sweating, dry mouth, dizziness, drowsiness, constipation, blurred vision. Side effects of naproxen: stomach pain, dizziness, constipation, diarrhea, gas, heartburn, nausea, and vomiting. With both medications have a side effect of dizziness, it would be good to keep close observations on the patient, close observation of the patient throughout the treatment. Some test and measures results. For knee flexion of the right, we have measured 75 degrees. Knee flexion of the left, 82 degrees. Normal, 130. Measurements of the right dorsiflexion, 5 degrees. Measurements of the left dorsiflexion, 8 degrees. Normal, 20 degrees. Lower extremity strength, hip flexion, 3- out of 5, bilaterally. That means both. Lower extremity strength of the hip extensors, bilaterally, 3- out of 5. Hamstrings take minimal resistance in sitting. Plantar flexion, dorsiflexion, eversion, inversion, all of that, every one of those, 4 out of 5. The patient is weight-bearing as tolerated. The patient is able to walk 20 feet with a front wheel walker and minimum assistance. The patient demonstrates a lateral trunk lean and decreased bilateral step length and minimal knee flexion with bilateral circumduction gait. The patient is able to walk up 4 steps with 2 rails and minimum assistance. Patient needs a minimum assistance to roll, moderate assistance to scoot up in bed, contact guard for assistance with sit to stands, minimum assistance for a stand pivot transfer with a front wheel walker. The patient's sitting balance is fair while using bilateral upper extremities for support. The patient's sitting tolerance is 20 minutes at the edge of bed. The patient's sitting tolerance in a chair is 2 hours. The patient's standing balance is fair with a front wheel walker. The patient performed the Berg test, B-E-R-G test, and scored 39 out of 56. It would be good to have continual, up-to-date communications with the patient's medical provider, the patient's doctor. So as a patient progresses, the doctor can modify the appropriate medical dosage. The nurses will be valuable in keeping the patient comfortable throughout the day, and perhaps assist the patient when needed with the home exercise program in order, like getting the straps or towels when needed to perform the home exercise program. It would be good to let the nurses know the patient's goals and progress so they can help motivate the patient, perhaps through daily conversation. It would be good to check in with the nurses before sessions to help assess the patient's current mood. If the patient had a rough night or difficult morning, they didn't sleep well or they didn't eat much in the morning, knowing this may help prepare the therapist for perhaps a more challenging session. In this case, a dietitian would obviously be valuable. It could work on the patient's obesity by providing a healthier diet plan for the patient to follow to lose weight. A social worker would also be helpful to assist the patient transition back into a comfortable working environment. It would be helpful for the patient's boyfriend to come during a session to learn how to assist with transfers, gait, and functional mobility around the house to help with the patient's activities of daily life at home when needed. So the plan we have is for the patient to be seen twice a day for bed mobility training, transfer training, balance training, gait training, family training, diabetic foot care training, therapeutic exercises, therapeutic activities, and home exercise programs. So, the goal right now is to get the patient back. Get the patient back to being an active and participating member of society in 2 weeks. Good luck.